right, we're ready to start the fifth panel. If everyone can please come into the room and take your seats. So I hope you all enjoyed the coffee break and got a chance to see all of the exciting innovations we have in the Innovation Showcase. Our next panel has a very ambitious role of suggesting the ways that we can move forward better to better accelerate universal health coverage. And they will discuss in particular how international partnerships can work more effectively to support countries that are pursuing universal health coverage. To lead that process, I am pleased to introduce the moderator, Ariel Pablos Mendez, a professor at Columbia University, and the former assistant administrator for global health at USAID. Ariel?
Thank you very much, and good afternoon, everybody, and I'm glad that we all get a chance to have a little bit of coffee. As an earlier champion of the global movement for universal health coverage, I could not be happier, really, with the energy, the commitments that we have seen this morning. Well, actually, I can be happier, and by having a much more balanced, gender-balanced panel this afternoon. The session is on the way forward. Each of the members of our panel, which I'm honored to have here together, has already been committed to this agenda in different ways. And so what actually does it mean to move forward with the UHC agenda? The objective of the session is to mobilize political support as well as commitment for resource mobilization and innovation, especially at the national level, highlighting the importance of both Ministers of Health, Ministers of Finance, civil society. And we have a fantastic panel to do so. We will start with the Honorable Minister of Health of DRC, Dr. Kalenga, and after his intervention, we will have some other interventions by the distinguished members of the panel. You all have in the materials the detailed background of each of the panelists. Margieta Jagger is the Deputy Director General of Development Cooperation, the European Commission. Seth Berkley, known by all of you as CEO of Gavi, the Vaccine Alliance. Mark Sussman, the CSO and the President of the Bill and Melinda Gates Foundation. Marike Winsrow, who has been a wonderful interim Executive Director at the Global Fund. Miriam Clayson, who is the Director of the Global Financing Facility. And Álvaro Bermejo, who is the incoming Director General of the International Planned Parenthood Federation. Each of them will have a contribution, and then we hope we will have some time left for some questions and answers with all of you. So to start us off, Minister Kalenga, thank you.
Good afternoon, everybody. So it's my pleasure to be here with you to share the experience of DRC. And first of all, let me remind you the context. We have a very low budget, annual budget of 5 billion for a big country like DRC with nearly 100 million population. And the allocation of public resource to healthcare is very low. It's 5%. And then the direct out-of-pocket payment from the household represent 40% of the annual budget. And the fragmented external assistance represent 35%. So as you can see, these are very tough conditions to start the journey toward the universal health coverage. And as a Minister of Health, I see my position as the custodian of the interests of the population. And my perspective is to try to get the most value for the population out of every dollar spent in the healthcare sector. So you can imagine that allocative efficiency and technical efficiency are very fundamental dimensions. And the focus must not be anymore on just input and planning, but the focus must be on results and cost. So you see that we've entered a new era, is the era of health economics. It's not just anymore public health, the old public health paradigm, but it's health economics, very, very important. And to achieve the universal health coverage, we have a national health strategic plan. But our plan, when it was written around more than 4 years ago, it was too broad, too ambitious to be funded, and it was not really costed. So as a consequence of this, the donors have room to make what I call implicit prioritization according to their individual agenda. And thanks to the GFF helped us to overcome these challenges because the GFF has supported the development of a health financing strategy. And above all, we've also developed an investment case prioritizing high-impact interventions for reproductive and maternal and child health. To a large extent, this agenda is a universal health coverage agenda for every woman and every child. So we decided that this agenda would be our first step toward universal health coverage. And so under GFF umbrella, 6 partners created a platform around a set of goals. They decided to work together in 14 of the 26 provinces of the Congo. And they covered almost 50% of the population. And they aligned around the followings. They decided to have the same services packages at all levels. Performance-based financing was used to purchase healthcare. They used the same tools and financing instrument. They also used a common support mechanism for health, human resource management, public finance management, data and health information management system. And we also managed to have, at the decentralized level, a pooling of domestic and external resources. So these are what we have achieved so far. But we still have some challenges. The following steps are to try to extend the harmonization to other areas, like supply chain, and see also more partners join the platform. We hope to have all the partners working in DRC to join the platform. Another point is to scale up the approach to other provinces. We started with 14 provinces, we are 12 remaining. So we'd like to scale up the approach and also to extend the approach to other healthcare problems. Because we started with maternal and child health, but there are many other healthcare problems in the country. And the third step will be also to abandon the vertical approach, which was inherited from Millennium Development Goals, and we have to move towards a more transversal and integrated approach. Because within the healthcare system, everything is interconnected. And at the community level, at the bedside of the patient, healthcare, whether it is for vaccine or malaria treatment, TB, or HIV treatment, all healthcare are provided by a single health professional. So all the vertical programs for mother and child must be integrated to be effective. And if you really want to move toward universal health coverage, we must all have one plan, one performance framework, one pooled funding, which must be, with the funds must be disbursed, with disbursement of funds upon delivery of results, we must have one report for everybody. If we want to have more transparency, more accountability. But the real question, if we really want to move toward universal health coverage, is to know how far are we and are the partners ready to go to have and to make reforms within their internal system, for the country to make reform for the public finance management, in the implementation of a finance strategy, healthcare financing strategy. So we must all make efforts, and the question is, how far we are ready to go, because, as you know, universal health coverage is not just about healthcare issues, it's also about socioeconomic issues and even political ones. So the question is, how far we are ready to go and how quick we are ready to go. Okay, thank you very much.
Wonderful. That's the right question for our panelists. And as you noted, it is the time for health economics. And I'm glad that you have that rich background as you bring into the ministry. Leveraging the Global Financing Facility as a new way to engage domestic resources in an integrated fashion as a platform for universal health coverage, and moving from the MDGs approach to a more transversal, integrated approach. And I think the next panelist, Seth, you have, of course, worked in global health. You have seen the space from all angles. From the Vaccines Alliance perspective, how can you speak to this issue of the integration of the transversal approach that the countries are moving towards?
Thank you so much, Ariel, and I think I build well on what the minister has laid out. I want to start off because one of the questions is asked as well, if we focus on vaccines, we are therefore a vertical program. But I want to start on the other side, which is, of course, vaccines don't deliver themselves. And the challenge in working with vaccines is not in the easy-to-reach areas. The challenge is this is the intervention that is most commonly delivered in these countries, but there are still many that are left out. And it was interesting, when we met with the Prime Minister early, Tony Lake said, you know, one of the things we've learned in UNICEF, speaking, he said, is that it costs more to reach that person that's left out, but because they don't have other interventions, when you invest in reaching the unreached, you end up with much better health outcomes. So when I think about what it is we're trying to do, is we're trying to help countries focus on having the data to allow them to determine where their systems aren't reaching, investing in those areas where the systems aren't there, and at the end, as the minister has said, that woman who is in that village at the end, who may be there initially to work on vaccines or other interventions, is at the end the health worker using the supply chain, the surveillance system, the data system, the outreach that is necessary to do that. So this is something that we have to do. And what's been very interesting is that it's changed. It used to be that it was the hinterlands that one worried about in the developing world, but more and more it is urban slums, for example, where people are being missed because people are flocking into urban areas for jobs, or it may be ethnically isolated areas where there's stigma against groups. And so, as the minister said, this cuts across a whole range of issues, and it's about getting this consensus that we want universality in our approach. The last thing I want to say is that, you know, I certainly believe in what the Lancet Commission for Global Health suggested, which is progressive universality. So one of the challenges is the allocative efficiency that was talked about, how we get prevention out, how we get cost-effective interventions out that can make the most difference, and then as we get to universal levels, building on top of that, because there is a danger in the universal health movement that will do a veneer of activities that will not provide the best outcomes. And of course, it's most important in resource limited places to make sure that you spend it on the right thing. It's less important in places that are very wealthy because they can waste more money, even though we're not trying to suggest that. But it's really in the places that have the limited funds that we have to make sure there's really good allocative efficiency.
Thank you, Seth. And the minister also spoke about the need for integration not only of the services, but coordination among donors. And we are lucky to have from the European Union, Margetta, just a reflection on how, the European Union has been very successful, I think, in bringing together several donors, in being transparent about the resources you put forward in the countries. We would love to hear from you on how we can respond to the minister's plight. Thank you.
Thank you very much. Your Excellency, dear guests, first of all, on behalf of European Commission, I would like to thank the organizers, Japan and other co-partners, for organizing this forum. And of course, I am extremely honored to be part of this prominent panel, so much gender balanced, and therefore I would like to say not only the gender, but also the universal health coverage is the EU priority, and it's enshrined in new consensus on development. As you all know, also the EU follows the rights-based approach and seeks comprehensive strengthening of all areas of the partner countries' health system, because we believe that only strengthening all areas will bring the comprehensive approach. And this is central to moving towards universal health coverage with the health services accessible and affordable to all. And of course, to come to the last woman and child in the village that the Minister mentioned. We also believe that a sustainable and strong and resilient health system can only be achieved through the joint and coordinated efforts of all partners, donors and the partner countries. So you ask me what we can do better, and of course this is a very simple question, but it's a very complex as well, and the answer is not one line. So we believe that a better coordination and alignment at the country level is needed. That is something that we would pledge for. Also, we would be in favor of some new partnership and new tools. And what happened in Paris on One Planet, the partnership with the private sector, namely with the Gates Foundation on the research on sustainable agriculture that will bring innovation and research in the food security and save a lot of kids from malnutrition is one way. Also other initiatives when it comes to the health and gender would be needed, and then the private sector involvement is needed. You have probably heard about our very ambitious external investment plan, where we put together the guarantee and guarantee fund in order to crowd in the private sector, because only the public-private partnership is a solution in the long run, and we believe that the solution can only be found on the long run. And then essential, as mentioned before by Minister, domestic resource mobilization, and of course the finance ministers to be convinced that investing in health is an investment rather than a cost. And here it's our job, of all donors to coordinate and get this message across. But you asked me how we can ensure the transparency and predictability of our donations. And of course, why don't we have some kind of matrix? And not only that the EU is a champion when it comes to the transparency and predictability. You all know about our MFF and multi-annual financial framework that plans for 7 years, that brings a lot of predictability, and when it comes to reporting and accountability, we are annually publishing all disbursements that are publicly available. Therefore, the mapping is not very difficult to do, but how to ensure the transparency and predictability at the level of all donors. This is a question that we can collectively answer, And also, I would say that predictability is a key for enhancing domestic accountability around the budget process, and Minister will probably agree, and more effective domestic resource mobilization. So yes, we have a lot of work to do. We need to be better coordinated, and I can only share here the commitment of the European Commission that we are going to enhance our cooperation at the donors level in order to strengthen the health system in order to achieve the SDG 3 and related targets according to the plan. Thank you very much.
Thank you very much. And indeed, the EU has been a champion on transparency, coordination, accountability, and the emphasis on coordination among all of the players, very important, specifically also coordination with the host governments, as well as coordination between the public and the private sectors, because it's essential to move towards universal health coverage. And I guess doing a lot of that is what the GFF has been born to do, and particularly in terms of the possibility of leveraging domestic resource mobilization, which is the central theme of the post-2015 financing for development. Miriam.
Thank you so much, Ariel. And I must say that the presentation by Minister Kalenga has made my task very easy in trying to explain how the GFF operates. But I also like very much to acknowledge and thank all my fellow panelists, because it's only through our collective impact in support of country leadership and with active engagement of CSOs that we will make a significant accelerated progress on UHC. So that's why it's so exciting, I think, to be here today. So let me say a few words about the GFF and also clarify up front. Maybe I should actually mention someone who's not on the panel, and that is our government host. And I also would like to really acknowledge the role that JICA has played from the very inception of the GFF, and particularly at the country level in Senegal and Kenya and other places. So just to be very clear that it's really through very many players all contributing to the GFF partnership that we're making progress. One thing that's very important for us in the GFF is to focus on the outcomes of women, children, and adolescents, those critical periods of the early years around birth, early years in adolescence. It's not only because that's where the large disease burden remains in poor, low-income areas, but it's also because that's where we can get the greatest impact and benefits from investments. So that's very important. So how do we work? How do we do the work with governments to mobilize domestic resources and increase the efficiency? So the GFF is not a fund that focuses on a specific disease or intervention. It is a facility, and it's a facility that uses very small catalytic funding to try to grow the envelope for health. And we do it through 4 mechanisms. One is through domestic resources. The second is really to link to IDA and IBRD concessional financing. And of course, we have the benefit of being housed at the World Bank to get that entry into the financing that they can provide. Thirdly, it's really to support countries' effort to align bilateral and other external resources. As we have heard from several ministers during these 2 days, how to align our multiple partners around their priorities. And fourth, it's really to bring in also private sector financing. How do we leverage the large private sector out there for health, both as a service provider, but more importantly as a financier? So what we do is really to support that country process and that country platform. And the benefit of working the way we do and strengthening primary healthcare systems is not just that we can increase the coverage of reproductive, maternal, newborn, child, and adolescent health and nutrition interventions, but it also provides a very strong platform for the future and evolving NCD agenda. So we don't see a dichotomy there, but rather a continuum. So how is the GFF fit for purpose? How can we play this catalytic role? First of all, the fact that, as I mentioned, that we're housed at the World Bank gives us entry into the macro dialogue, the financing reform, and the financing agenda, so that we can bring this discussion we're having here about allocative efficiency and high-impact interventions and looking at how to get more money, value for money. Secondly, we have evolved from results-based financing, so this strong focus on results, on governance and accountability for results is, of course, another very important element. And thirdly, the fact that we engage in the country process that use evidence and an equity lens to really identify the highest impact interventions and systems bottlenecks. Now, that's not sufficient, right? We can do our utmost to try to improve efficiency, but how do we also grow the money, the envelope for health? We have heard earlier in the previous session from Kenya, and they actually use GFF and IDA financing to do that, incentivizes the counties at the subnational level. So let me just give you one example, because you have heard also from others about smart scale and sustainable financing. Let me mention Guatemala. Guatemala is a country that has transitioned, is in transition. It's not anymore an IDA-eligible country. It uses IBRD loan money. So there we're using our financing really creatively and innovatively, saying let us pay down your interest, buy down the investments to concessional level, and then Guatemala will do what we are discussing here, provide the domestic resources and match the savings that they get from the buy down of their interest. That combined is then put into a national stunting plan to really address a remaining issue in the country around stunting. So that's just to tell you how we can use our financing, both just to add value, but also finding ways of creative financing with partners. Thank you.
Thank you, Marianne. Thanks for your leadership. I think that GFF, as a provider of catalytic role, because it's convening many other players to expand the pie for primary health care, to bring more money for health, but also through results-based financing and coordination, more health for the money. And again, even though it's a bigger partnership, it is great that the World Bank is so committed, as we heard from Jim Kim this morning, to primary focus on human capital. And I think this is a good manifestation of that. One of the champions that has really helped transform the era of global health has been the Global Fund, both as a player in the global health sense of driving key agendas through financing, but also as a great example of the importance of mobilizing civil society. Social movements are paramount to advance any agenda, and clearly for universal health coverage, there's much we can learn. And for that, Marieke, we would love to hear from you.
Thank you very much, Ariel. And the Global Fund is a partnership at its very core. And as I'm looking at the people on stage, you're all partners. We all partner with each and every one of you in different ways. And you would not have achieved the impressive results, 22 million lives saved and counting, if it had not been for the entire partnership coming together. Country governments, obviously, like the minister, obviously play a very key role here, but I will stick to the question and focus on civil society, who are and always have been critical partners at all levels. This is also reflected in our governance model, where civil society as well as communities affected by the three diseases fully participate at the global and the country level. And at the country level, the country coordinating mechanism, the CCM, is the mechanism to ensure that inclusion. That was groundbreaking when the Global Fund was launched in 2002, but for us it was a no-brainer. Civil society organizations have crucial roles to play in program development and implementation, in advocacy and in accountability. We encourage countries to have at least 40% of CCM members representing civil society, using quite a broad definition, and most countries do meet that standard. CCMs were never intended to be standalone bodies, and countries were encouraged to use existing coordinating bodies as long as inclusion and space for meaningful dialogue would be guaranteed. The sad reality was that very few existing bodies met those criteria, and civil society participation, if at all existing, would be tokenistic at best. So most countries set up CCM separate from other coordinating bodies, although many sought ways to coordinate and share information. Over the last 15 years, CCMs have played a critical role in creating a platform for true civil society engagement. And they have been instrumental in the enormous progress that we collectively have made. That doesn't mean that CCMs function perfectly everywhere. The functioning of CCMs very often is a reflection of the level of democracy in a country. In some countries, they have very strong CCMs that are truly inclusive, give voice to groups that are often marginalized, and perform strong program oversight. In other countries, CCMs are dominated by the institution with the most power and program oversight is haphazard. And as always, many countries are somewhere in the middle. And not surprisingly, program performance is better in countries with strongly functioning CCMs. Like democracy, CMs are work in progress. We're currently reviewing the CCM model to see how they can further evolve and improve, and how they can better support the fight against the 3 diseases and build resilient and sustainable systems for health. And you asked for some lessons learned from CCMs that are relevant in civil society participation, that are relevant to the broader UHC movement. There are many, but I will just limit to 3. The lesson 1, civil society is broad and might have different starting points. In the Global Fund context, civil society participation was very strongly developed around HIV. The GPA principle, greater involvement of people living with HIV/AIDS, was already introduced in 1994, and the nothing about us without us was a well-established principle. Civil society engagement in the TB and malaria community was less developed, and that took time to develop over the years. And as the civil society movement in health is broadening, it's important that we have common messages that everybody can rally around. A fragmented civil society voice will not be heard. I applaud the efforts of the civil society organizations that met earlier this week in Tokyo to develop their message to this UHC forum. It's important to agree on shared principles, such as the right to health, leaving no one behind, access for all, good governance, transparency, and accountability. And I encourage all of you to read the civil society statement. A second lesson is it's not enough to open space for civil society. Participation alone does not guarantee voice and influence. You need to establish support mechanisms to enable civil society to participate in a meaningful way. And this is especially true for smaller national civil society organizations and community networks. If you really want the voices of the most vulnerable population to be heard, we have to empower them and support their capacity building, and the Global Fund has invested a lot in that. The third lesson, the Global Fund is constantly evolving, like all of us. We started as an emergency response in public health crisis, and our current strategy, 15 years later, aims to end the 3 diseases as public health threats, in line with the SDGs targets, and focuses on maximizing impact of investments, on building resilient and sustainable systems for health, on promoting and protecting human rights and gender equality, and on raising more resources, including from the domestic budget. And this means a broader and more integral approach that the Minister of Health of the DRC was talking about, but it also means that the role of CCMs and of civil society will have to evolve and become more strategic. Some countries, including Myanmar, yes, I'm finishing. Some countries, including Myanmar, have broadened the role of CCMs to provide steer and guidance for the entire health sector with a view to achieving universal health coverage by 2030. It's not up to us to prescribe countries how to organize themselves around UHC, but we do believe that the underlying principles of full participation of all stakeholders and meaningful engagement that underpin the CCMs are going to be crucial to achieving UHC and health for all. Thank you.
Thank you, Marieke. Wonderful. And we heard from the minister that for USC, he has a vision of the 3 ones that we had heard also from the Global Fund, a great contribution. And of course, we also know that USC is not just about health sector or about financing. It's really about the governance of the sector and the stewardship of society, the vision that we want for our people. And that cannot happen without civil society. So I'm very happy that the experience of the Global Fund can be also a platform, an experience that we can learn from at the country level. And we are lucky also to have with us Alvaro, who represents indeed one of those civil society organizations at the international level, but also with a lot of grounding national partners. Alvaro, How has the coverage of family planning expanded under universal health coverage, or how can the voice of civil society advance that and other priority agendas for the people?
Thank you, Ariel, and big thanks to Marika, as I thought I was going to speak on behalf of civil society and many other organizations beyond IPPF, but it's good that the Global Fund has done that, and I too would encourage people to look at the joint declarations that civil society has produced for this event. So Ariel, your question is, how much progress has UHC made for reproductive health? And of course you know that the gap is still huge. So 200 million women still do not have access to contraceptives, even though they want to delay or avoid their pregnancy. And I use that indicator because it's the one most commonly used. We could be talking child marriage, gender-based violence, safe abortion, a whole lot of other things. So I'm sure that it's no surprise to anybody that for IPPF and for most of us, comprehensive sexual and reproductive health services must be a centerpiece of UHC. And that makes economic sense. There's been many models that show that the savings or the net benefit of adding contraceptives to the traditional maternal and newborn package will produce a net saving of $6.9 billion. So IPPF, with its 152 member societies working in 172 countries, does this and has no refusal policy so that anybody that comes to the clinics can receive the attention they need. And in doing that, we've learned three things that I would highlight here to try and answer your question. The first one is from research done with DHS data over the years, which shows that still today, large number of women around the world see reproductive health commodities from the private sector. And I use that term broadly to refer private commercial, NGOs, and social marketing. And in many cases, this is particularly true for countries like DRC and some of the poorest people in these countries. And I used to believe that the reproductive health commodities market in low and middle income countries was a donor-dominated market. That's what I thought. So when I learned these figures, I was quite shocked. 17% of the 1.2 billion that was spent in 2015 on reproductive health commodities was from government expenditure. 25% was donors, but a whopping 58% was out-of-pocket private expenditure. 58%. Shame on us. The second lesson is that stewardship, even in these circumstances everywhere, stewardship from the private sector is critical. And that we need to remember what I thought was a very nicely titled report that was entitled, as noted in No Product, No Universal Health Coverage. If we don't have supplies, there is no universal health coverage. So it's very important that countries implementing UHC reforms will act with total market considerations over time in a progressive way and under well-functioning stewardship from the private sector. If when we do this, we can and we will see health family planning marketplaces that are healthy and that evolve in line with UHC. And we've got two examples that have done that well that I'd like to highlight: Thailand and Mexico. In Thailand, the UHC initiative that was launched in 2002 improved the utilization of SRH services among all income levels, increasing equity. In Mexico, the social protection system in health expanded health coverage and reduced out-of-pocket health expenditures, increasing skilled birth attendance and antenatal care as well. I'd also encourage everybody to come tomorrow to the side event to hear about the experience of IPPA member associations in Kenya, Sudan, and Cambodia, which are very much in line with this. And the third and final lesson is that even where SRH services and supplies are included as part of UHC, there is no guarantee, and in many cases we see that they're neither comprehensive or universal. So we see a number of countries which have included some methods of contraception and maternity care, but where other methods or services such as abortion and post-abortion care have been neglected. Even more importantly, we see countries that under so-called UHC exclude large segments of the population, be them unmarried women or adolescents who require parental consent to be able to access these services, which are still called universal, but of course are missed. So to conclude, I would say by promoting universal access to sexual and reproductive health services that are stigma-free, that are good quality, and that are affordable for everyone, IPPF and many other civil society organizations contribute very much to universal health coverage and vice versa.
Wonderful, Albert. I think that there's a very rich agenda because of the problems of exclusion that societies may still have, even as national health security schemes get formed. So very, very important. You also point out that you were shocked to learn that it's 58% of the family planning services and commodities are being paid out of pocket in private provision. And this is not so much a revelation, but is the result of the transition that countries are in the midst of. As very low-income countries where it's pretty much the government and some of the NGOs that support with donors the provision of essential services, as those countries get up economically, and this has been happening, half the countries that were low-income in 2000, more than half, are now in the middle-income stage. As that happens, there is an explosion of the demand that is met by the provision by private providers. And so, and the financing and the organization of all of that is not always harnessed by ministers of health who are a bit overwhelmed sometimes by the rapidity of the change and the need for new forms of financing. But I think 58% is indeed what you will find in many other areas of services, that the out-of-pocket way of financing, which is inherently inequitable and inefficient, is indeed one of the issues that universal coverage is to tackle. So thank you for making that very important point. We will have now time for some questions and answers. So if you could raise your hands. Sorry, I'm very sorry, Mark. I left you out. I skipped you actually earlier on, Mark. I'm so very sorry. Mark, the Gates Foundation has already done a lot in this space. We all heard this morning, and it was wonderful to hear Bill Gates' commitment to primary health care and to universal health coverage. But also, in addition to innovation and technology, the foundation has been characterized for measurement. Without good measurement, as we heard early this morning, we will not be able to know where we are and where we're going. So can you tell us how the foundation is engaging, particularly in the primary healthcare movement, with measurement?
Well, thank you, Ariel, and thank you all for the patience of bearing with. We are a large panel, and so it's easy to overlook one of the panelists. But I think it's large for a reason, and it's important because one of the key lessons that we've had over the MDG era, which has been referenced, is that to get success in global health, you really need partnership, and you need partnerships that are thinking about measurement and metrics. And what the MDGs really help drive by having a set of clear targets around child mortality, around maternal mortality, around HIV, TB, and malaria, was a new relentless focus that helped bring together donors, developing countries, civil society, and others in an unprecedented way that also had unprecedented results. And that was an incredible platform to build on for the Sustainable Development Goals. What is fundamentally different about the SDGs is, as already been said and referenced by the minister, is that although the MDGs aspired to be country-led, in practice they still were largely donor-driven. The SDG era has to be one that is fundamentally driven by, owned by the developing countries themselves on the basis of their own national plans. And what we as a community has been is, to some degree, while we were part of this great series of successes during the MDG era, and the Gates Foundation is very proud to have partnered from the inception with the Gavi and the Global Fund and everyone else on this panel and many others in the room, is also we were ourselves a little bit less than the sum of our parts, and to some degree contributed to the problem because we did have some parallel systems and structures and processes. And now with the SDG framework, which continues to focus on those key targets like child and maternal mortality and infectious diseases, but broadens it and has at its heart this vision of universal health coverage. And an understanding that this is a common framework that can draw all of us on this panel and in this room together, but it has to be drawn together around a shared framework that, again, has concrete metrics and actions attached to it. And we know, again, that 90% of the global health disease burden that we face to meet the SDGs can be addressed through successful, well-financed primary health care. But we don't have the tools and metrics to let us know when and where that good primary health care exists. So one of the steps we are taking at the Gates Foundation, working closely with the World Bank and the World Health Organization, but also, and I stress back to the point, working very closely in dialogue with developing countries themselves and their health ministries about what's going to be useful, is trying to come up with a new primary healthcare performance initiative, which really looks at service inputs, outputs, and service delivery at the heart of it. How can you see whether the right trained personnel are there making the right decisions? Do we have the supply chains working? Are the financial resources coming through? Are they being integrated in the right way? Are they being turned into a platform that really helps drive common outcomes and results, whether we're looking at vaccines, whether we're looking at antiretrovirals, whether we're looking at a wide range of interventions from family planning to NCDs? And I think that's where we are now, and I think that's also where the Global Finance Facility really, as the first new financial instrument of this SDG era, has a really important role to play, helping become more of that common platform, driven and led by developing country partners like the Honorable Minister, with a shared framework that all of us, donors, the private sector, civil society, and others can come behind and implement, because that is going to be the essential platform by which we reach those SDG outcomes and by which we can judge the metrics of where and how and when the right investments in primary healthcare can and should be made. Thank you.
Thank you, Mark. I spent many years at the Rockefeller Foundation, but there's never been any sibling rivalry on that, so apologies for that slip. Thank you. We can now move to some questions, and I see some hands. We're going to take 3 or so questions and then allow the panel to respond. Please just state your name and the institution you work for. Please.
Hi, Ariel. I'm Dennis Gilhooly. I think you know who I am. Ariel, I'm a bit conflicted here because you were the man at the Rockefeller Foundation that gave me the grant to start the United Nations Digital Health Initiative. But a few questions for the panel. Mark, the Gates Foundation is based in Seattle, which is a lovely town. I lived there once, and as you know, I worked for Bill. Now, you've had a Chinese war between Microsoft and the Gates Foundation in terms of entering digital health for some time. But isn't it time that you actually rethought the fact that the tidal wave of digital health is the only way that we can possibly meet the Sustainable Development Goals, and particularly SDG 3?
Thank you, Dennis. I see a hand in the back.
Merci. Je suis Moinor, je suis des îles Comores, c'est dans l'océan.
I come from the Comoros in the Indian Ocean, and I'll speak French, if you don't mind. I have a question to the lady from the European Union, because she mentioned traceability, predictability, transparency. Non desu ka?
Mais quand on regarde la réalité dans les pays,
if you look at reality in the countries in practice, you see that the partners are doing exactly the opposite. Each partner comes in with their own procedures, their own modus operandi, and in each case, each partner wants to be the leader for whatever it is that they're doing. So it is a problem for the national entities. And now I've heard somebody referring to C5 for the Global Fund. There's also the CCIA for Gavi. I'm not sure what these acronyms are in English. There is also, with the agencies in the UN system, the UNDAF, to coordinate the various actions of the UN. But still, each one of these entities is doing its own job at its own corner. Couldn't you all say that you're working around the CCM? Because the CCM is represented by civil society. You will find communities there. You find the national counterparts there. You find the private sector is present there too. So perhaps it's by working around the CCM that you'll get better coordination. Perhaps then it'll be clearer how aid should be coordinated, how to coordinate the aid at the level of a country. And I have a second remark or question, and I'm speaking only on my own behalf. When you go to support a particular country, every partner takes a whole year to conduct studies and surveys, to send in experts and consultants. And 40% of the budget will be devoted to all that preliminary expert work. And then how much goes actually to the country for actual implementation on the ground is very little. So I would really like the real questions to be put and the real answers to be provided. Thank you.
Thank you. Very good questions. Afsana,
I'm Kausar Afsana. I'm from Bangladesh. I work at BRAC. I just, for the last 2 days, I wanted to reflect that we probably touched and probably haven't touched much about the fragile states and also the countries which are affected by the climate change. And those countries, one of the countries, indeed Bangladesh, is suffering from climate change and also suffering from the humanitarian crisis and also from the man-made disasters. So I would like to flag that issue that if this is the era of SDGs and we haven't talked about SDG 16. So how are you going to bring peace, justice, and accountability? And who will be accountable to those? Is it the country? Because SDGs is the country-led movement. But who will be accountable to all those things happening across the world? So I would like to flag that issue among this August gathering. Thank you.
thank you very much, Afsana. I don't see a hand now. Well, there's one more here from Liberia.
So thank you very much. This is one of the sessions that interests me because we face a lot of problems in our country when it comes to the multiplicity of partners and the difficulty in coordinating and aligning them to our national priorities. So my question is, in practical terms, how can countries work with these very many partners to ensure that we align to what our priorities are and not to what the interests of the partners are, because that's the only way together we can make the UHC dream to be a reality.
Thank you. And indeed, we started the conversation of the panel precisely with the point of coordination. And but we would love to hear from you. Some questions were more specific. Dennis asking Mark about the role of digital health in our...
Well, actually, it was beyond Mark.
Yes.
I'm asking how digital health can be enshrined in UHC.
Wonderful. So we will invite the panelists, each of you, to react to any of the questions. One, on the importance of digital health on our way to universal health coverage. And then the importance of partners' behavior and coordination at country level, as well as how the resources indirectly from that, how the resources get spent within the country as part of the support. And then we heard also from Afsana the role of this movement in fragile states and going beyond the health sector to climate change and so on under the SDGs. Can we start with Miriam, perhaps, and we go this way?
Thank you. I think you raised some very important questions around who takes the lead in the country. And clearly we've reached a point where it has to be country leadership. And that's the biggest change. We all talk that talk, but how do we ensure that countries like the examples we've heard here from DRC, Liberia, and others during these 2 days, how do we ensure truly country leadership? We think that that's the most important, and that's the change that has to take place. Also, I think it is important to enter as a player without a blueprint and really be guided by the priorities of the country. So that's the sort of walk the talk that we are trying to do with partners. You said something about existing platforms, and we heard you talk about the CCM. I think where there is an existing platform, anyone who enters there should build on the existing platform. And I think that's an important message for this UHC forum. We don't need to create another new platform if you have a functional platform. And by that, I mean one that has meaningful engagement of CSOs and all the partners. The private sector has a real role to play. So I think you brought up some very important points there that we take to heart. Thank you.
Thank you very much. Seth.
So building on what Miriam said, for me, the critical issue is having the tools in place, and it answers a little bit of what Dennis is saying. At the end of the day, countries have to be able to understand fully what's going on in those countries, and then to be able to allocate resources based upon that. And it has to be led by a country. Now, we also need, and nobody's mentioned this, normative guidance. And so one of the challenges for this UHC movement is to really begin to work on, for each country at different level, what is the type of engagement they should do? Where should they invest their money? What type of health workers do they need at different centers? Where are community health workers able to do that? And Dr. Tedros just walked in, so perfect timing in bringing that up. But I think it's really important that we help support the country, because I agree with Miriam, at the end in this era, only the country can lead these critical discussions. But without that data, we end up with a situation where a lot of the resources are not focused on the most cost-effective interventions or the ways we can get the maximum improvement in health or in prevention. So these are some of the priorities that have to be dealt with. Lastly, on the fragile issue, it is really a complicated question, because at the end, one needs a national system, but we also have places that have no system working. And in those cases, it requires, depending upon the circumstances, engagement of a civil society, engagement of the UN partners and others to help try to put together some temporary dealing with these problems until we can come to a more further solution. Because, of course, one can't ignore those very needy places.
Thank you, Seth. Marietta, your team is coordination.
Yes, thank you very much, and thank you for a very, very good question about fragmentation. And of course, as I said before, EU as a biggest world donor collectively with the member states, we are fully committed to transparency and accountability and, of course, I would say, predictability. But here we challenge, the issue of how to work together. Yes, we are also all committed to work together and, of course, to work at the country level. And now, how do we do it, and who is the better placed for that? We would like to have an in-front donor coordination in order that, of course, we can match the expectation and the program and priorities of the partner countries. Basically, as a European Commission, we work not only bilaterally with the minister here that knows very well how much we invest in health system and all areas of a health system but also with, of course, all the global initiatives. We share quite equally 1.3 billion among global initiative and 1.3 billion bilateral aid. And of course, we are very much interested in the alignment and harmonization. But I do believe that we need to have some standard procedures and agree not only at the political level, but to give concrete instructions to our people on the ground that they will work together, and then the alignment will come also in the future. Thank you very much.
Thank you very much. Mr. Kalenga, could you speak to both echo really, as you stressed, the importance of coordination as well, digital health, if you would like to.
Yes, I would like to make a comment about the coordination, but also about the fragile state. I ended my presentation by saying that in universal health coverage is not only a healthcare issue, it's socioeconomic, but it has also a political dimension. So in many cases, one of the questions is, will we be able to reach universal health coverage without strengthening our states? So it will be very important also to strengthen the state, to strengthen the functionings of our states, if we really want to coordinate and to put our agenda forward and to challenge also the donors to ask them to follow our priorities. And I think that the more we'll strengthen our states, the better we will be in coordinating the agenda according to our own priorities.
Exactly. Thank you very much, Marike.
Thank you very much. And I will mostly focus on the last question because I think that's a really important one, the alignment with country priorities. The Global Fund in 2014, we moved from a round-based system to an allocation-based model where countries get funding for a 3-year period that they can then use to support national programs and national priorities. The extent to which that then really supports national agendas depends very much on political leadership at the country level. Political leadership is really key, and Dr. Tedros is writing down, but is now writing, listen Tedros, because I think the sort of political leadership that the Minister of Health, when you were Minister of Health, that you demonstrated, where you used the vertical funding provided by Gavi in the Global Fund to really build your system and really facilitate progress towards universal health coverage. It's really a model that I would like many more countries would follow, because sometimes there's an unhelpful divide as if vertical and horizontal approaches are in competition with each other. I think there's really ways to use so-called vertical intervention to really build systems. And even Japan, after the Second World War, when they were fighting a very significant tuberculosis epidemic, they used that epidemic, the fight against tuberculosis in the country, to then build a system and introduce the national health insurance system. So I would also then like to use the opportunity to advertise our side event tomorrow morning at 9:30, where together with Gavi and some really amazing ministers we'll explore how best global health partnerships can contribute to UHC. Thank you.
Mark.
Thank you. Well, maybe 2 quick points. One is just the emphasis. We've talked a lot about the coordination of donor funding, bilateral and multilateral. But again, I do want to stress that the fundamental vision behind the SDG agenda and the universal health coverage agenda is one where if developing countries are leading, they're also leading in maximizing domestic resource investments in the health of their own people. And we know that one of the challenges, often dealing with finance ministries, this room is a self-selected room of people who already understand the importance of deep investments in health. We heard from President Kim this morning about why you actually need a stronger set of measurements around human capital and the investment shortcoming, because basically human capital is systematically underinvested in most developing countries because it's a harder case to make. And 2 reasons it's a harder case to make are: 1, we're often not tracking the spending of those resources as effectively, and 2, you're not able to track the outcomes. And that's exactly, again, why the types of metrics that I was referencing earlier, being able to both look at where the investments are and then using tools like the new Primary Healthcare Performance Initiative we're working on with the World Bank and the WHO will be so important to helping drive results. And to Dennis's question, yes, absolutely. The backbone of this is going to have to be an IT-based backbone. We can see it in some of the work around universal ID, in tracking, in following supply chains. And so, we think this is an incredibly important moment to build on this, but to build on it in a genuinely coordinated way against a national plan driven and led by the countries themselves.
Thank you, Mark. Last and very briefly.
Thank you. I wanted to pick up on the question around fragile states and sort of UHC. And I can't add much because it's a complex question in very little time. But I'd only caution that we might be thinking too much 20th century. Strong state as a permanent thing and fragile state and conflict as a transitory, temporary setup. And maybe if we break that way of thinking and we think more of communities and individuals and self-diagnosis and self-treatment and what that means, we might get to a different answer to the question.
Wonderful. Thank you. Rich conversation. Key as we move forward for universal coverage is domestic resource mobilization, innovation, partnerships, coordination, national leadership, and implementation capacity. As Seth made a very important point, that we need countries to have that clarity of the blueprint, how they're going to move, so that all of the other members and partners can come together. And that is indeed, I guess, what the UHC 2030 partnership has been built to do, to provide that technical assistance, that guidance to member states, so that we can all work together under the leadership of the countries, governments, and communities as appropriate. I can only say thank you to Japan for hosting us. Thank you to Miki Chopra for co-chairing and the organizers co-chairing these sessions. And thank you, and invite you all to thank our panelists. Thank you.